About the lab diagnosis of streptococcal pyogenes infection. Specimen collection and transport depend on the site of infection. Direct smear microscopy pus cells with gram-positive cocci in short chains. Culture blood agar pinpoint colony with a wide zone of beta hemolysis. Selective media crystal violet blood agar. Culture smear gram positive cocci in short chains. Identification biochemical identification by catalase negative, bacteriacin sensitive, CAM test negative. Automated methods such as Marlitov and Vitek can be used. Typing Landsfield grouping shows group A Streptococcus. Typing of group A Streptococcus Griffith and EMM typing. Serology ASO antibodies and anti-DNase B antibodies. Antimicrobial susceptibility testing. Lab diagnosis of gas infections. Specimen collection and transport. It depends on the site of lesion. Common specimens are pus swab, exudates, and blood. For blood culture, blood is inoculated into the blood culture bottles. In streptococcal TSS, blood culture are usually positive. In case of pharyngitis, throat swabs are useful specimen. Direct smear microscopy. Gram staining of pus or wound swab reveals pus cells with gram positive cocci, zero point 0.1 to 1 micrometers. In this figure, we can see the streptococci and in the gram stained smear of pus and in the culture smear showing gram positive cocci in chains. Okay. Now, however, direct microscopy is not useful when Streptococcus pyogenes is part of normal flora in the sample. Example, a throat swab. Culture. The specimens are inoculated into various media and incubated overnight at 37 degrees Celsius aerobically in the presence of 5 to 10% CO2. Streptococcus pyogenes is fastidious, does not grow on McConkey agar and basal media like nutrient agar or peptone water broth. It grows only in media enriched with blood, serum or carbohydrate. Blood agar. Colonies are small, 0.5 to 1 mm, pinpoint with a wide zone of beta hemolysins. Selective media such as crystal violet blood agar can be used, which selectively allows the growth of Streptococcus pyogenes. Culture smear microscopy. Gram stained smear from the colonies show gram positive spherical cocci, zero point 0.5 to 1 micrometer, arranged in chains. Hanging drop reveals non-motile cocci. Biochemical test for identification. Catalase test streptococci are catalase negative. This test differentiates them from staphylococci, which are catalase positive. Bacteriacin sensitivity testing. Group A streptococcus is sensitive to bacteriacin 0.04 U disc. Any zone of inhibition around the disc is considered as positive test, while most of the other beta hemolytic streptococci are resistant. Hence, it can be used as a rapid diagnostic test for gas. Various tests used to differentiate gas from group B beta hemolytic streptococci are tabulated in the table. Automation for identification. Automated systems such as Vitek and Marlitov can also be used for rapid and precise identification. Now in this figure 52.5a and b, we see the streptococcus pyogene growth on blood agar with wide zone of beta hemolysis around the pinpoint colonies, and b figure shows that it is bacteriacin sensitive. In figure 52.5 c to e, uh, of Streptococcus agalacti, the C shows growth on blood agar with wide zone of beta hemolysis around the colonies. D shows bacteriacin resistance, and E shows CAM test positive. In this, we see the Streptococcus aureus streak line, Streptococcus agalacti, and Streptococcus pyogenes. Staph aureus, Streptococcus agalacti, and Staph pyogenes streaks lines we can appreciate. Now, difference between Streptococcus pyogenes and Streptococcus agalacti. Landsfield grouping. Streptococcus pyogenes group A and Streptococcus agalacti group B. Bacteriacin sensitivity test. Streptococcus pyogenes is sensitive while Streptococcus agalacti is resistant. CAM test. Streptococcus pyogenes is negative while Streptococcus agalacti is positive. Beta hemolytic colonies. Streptococcus pyogenes is 0.5 to 1 mm pinpoint, while Streptococcus agalacti mucoid slightly larger, 2 mm. Landsfield grouping. The biochemical identification of group A Streptococcus can be further confirmed by Landsfield grouping. Landsfield grouping is extremely useful in epidemiological studies. Hence, here The beta hemolytic streptococci are grouped serologically based on C carbohydrate antigen. Test involves extraction of C carbohydrate antigen followed by testing with group specific antisera. Typing of group A streptococci. Group A streptococcus can further be typed based on two methods: phenotypic method, that is serological Griffith typing, and genotypic method, M typing. Serology. In rheumatic fever and post-streptococcal glomerulonephritis (PSGN), a retrospective diagnosis of streptococcal infection may be established by detecting antibodies in patient's serum (ASO), anti-streptolysin O antibodies. ASO titer is elevated more than 200 international units per ml in most of the streptococcal infections except pyoderma and PSGN. It is detected by latex agglutination test and nephelometry method. Anti-DNase B antibodies titer more than 300 to 350 international unit per ml is diagnostic of PSGN and pyoderma. Antimicrobial susceptibility test AST. AST is performed by this diffusion method on Muller-Hinton agar with 5% sheep blood or by automated MIC detection method by microbroth dilution, example Vitek. Treatment. Streptococcus pyogenes infection treatment involves penicillin is the drug of choice for pharyngeal infection as well as for suppurative infections. Resistance to penicillin is not reported yet. However, failure to penicillin treatment may occur due to non-compliance if discontinued before 10 days of full course of oral penicillin V. Second, beta-lactamase is produced by normal throat flora such as Moraxella. Macrolides such as erythromycin is given to patients allergic to penicillin. However, resistant to macrolides is common. Treatment shortens the clinical syndrome, at least modestly reduces the transmission to others, decreases the risk of suppurative and other non-suppurative sequelae such as ARF. However, treatment does not reduce the risk of PSGN. Okay. Now coming on to the other beta hemolytic streptococcal infections. Group B streptococci, Streptococcus agalacti. Pathogenesis and clinical manifestations. Approximately 5 to 40% of women are vaginal rectal carriers of group B streptococcus GBS. Hence the GBS infection is common in neonates and in pregnancy. Group B streptococcus has been recognized as a major cause of neonatal sepsis and meningitis. Infection in pregnancy can lead to peripartum fever, endometritis, and puerperal sepsis. Infection in adults usually involve elderly or people with underlying chronic illness such as diabetes mellitus or malignancy. Common infections are cellulitis and soft tissue infections including infected diabetic skin ulcers, UTI, pneumonia and endocarditis. Group B streptococcus has a capsular polysaccharide which can be typed into 10 serotypes. Lab diagnosis. Isolation of GBS from blood culture and CSF culture are the mainstay of diagnosis. GBS is catalase negative like all streptococci but exhibits the following biochemical properties that differentiate it from group A streptococcus. Colonies. The colonies of GBS are beta hemolytic similar to that of Streptococcus pyogenes. However, they are mucoid and slightly larger 2 mm. Scam positive. CAM factors named after the discoverers Christie, Atkins, Munch and Peterson is a phospholipase produced by GBS that enhances the hemolysis of Staph aureus. When GBS is streaked on blood agar plate perpendicular to Staph aureus, an enhanced arrowhead shaped hemolysis is produced at their junction pointing towards Staph aureus streak line. Bacteriacin resistant species identification can be confirmed by Lancefield serogrouping and automations such as Marlitov. Treatment. Penicillin or ampicillin plus gentamicin are the drug of choice for all GBS infections. The treatment of Streptococcus pyogenes skin and soft tissue infection. Impetigo and PSGN can be treated by benzathine penicillin G IM single dose or oral penicillin V for 10 days. Erysipelas cellulitis treatment recommended is mild procaine penicillin and severe penicillin G. Necrotizing fasciitis treatment recommended is surgical debridement, most crucial, plus penicillin G plus clindamycin. Streptococcal toxic shock syndrome treatment recommended is penicillin G, clindamycin, intravenous immunoglobulin against streptococcal pyogenic exotoxin. IM stands for intramuscular while PSGN stands for post-streptococcal glomerulonephritis. Group C and G streptococci. The group C and G streptococci comprise of the following species: Streptococcus dysgalacti subspecies equisimilis. It carries both group C and G antigens. This is the most common species to infect humans, causes pharyngitis, cellulitis, and soft tissue infections, pneumonia, bacteremia, endocarditis, and septic arthritis, UTI, meningitis, and puerperal sepsis. Streptococcus equi, it carries group C antigen, has two subspecies, equi and zooepidemicus. Both cause infections animals, especially horse and cattle, rarely cause human infection, though through consumption of unpasteurized milk or contact with infected animals. Spectrum of disease include pneumonia, bacteremia, endocarditis, meningitis, and septic arthritis. Diagnosis: produce beta hemolytic colonies on blood agar of more than 0.5 mm size. Species identification is made by Lancefield serogrouping and automation such as Malditov. Treatment: penicillin is the drug of choice. Group F streptococci, they are also called as minute streptococci. They grow poorly on blood agar, occasionally cause suppurative infections. Streptococcus mg is an alpha hemolytic strain belonging to this group. Demonstration of antibodies to Streptococcus mg in the patient's sera has been used for diagnosis of primarily atypical pneumonia caused by Mycoplasma pneumoniae. Group D streptococci. Group D streptococci comprise of enterococci, fecal streptococci described, and non-enterococci, Streptococcus galoticus and Streptococcus equinis. Both groups possess the common group D lipotecoic acid antigen and gives positive bile esculin hydrolysis test, but differ in many properties. Compared to Enterococcus, non-enterococcal group D are more susceptible to antibiotics such as penicillin, do not grow in presence of 6.5% salt, less pathogenic to humans, not a part of intestinal flora. Streptococcus galoticus, formerly called Streptococcus bovis, and Streptococcus infantarius are the commensal of intestine of animals. In humans, they occasionally cause endocarditis associated with colorectal cancer or polyps. Penicillin is the drug of choice. Enterococcus and other streptococci. Enterococcus and other streptococci principally cause infection of various body sites. Therefore, they are discussed under respective infective syndromes. Enterococcus is non or gamma hemolytic, found as normal flora of human intestine, cause widespread infection including UTI, meningitis, intra-abdominal infection, and endocarditis. Within streptococci, they are alpha hemolytic, found as normal flora in oral cavity, may occasionally cause dental caries and endocarditis, subacute bacterial endocarditis. Streptococcus pneumoniae, it is an alpha hemolytic, primarily cause pneumonia, spread further to cause various invasive disease such as bacteremia and meningitis. It can also cause local infection such as otitis media and sinusitis. Okay, so now coming on to the expected questions. Chinu, a 3-year-old girl from Mangaluru, presented with tender, bright red subcutaneous swelling on malar area of the face with indurated pudgy orange texture of the involved skin, along with fever and chills. A clinical diagnosis of cellulitis was made. The culture of the aspirated pus revealed beta hemolytic pinpoint colonies. Clearly, this is a case of Streptococcus pyogenes infection. The valence factors, clinical manifestation, and the lab diagnosis can be done by us. Short note on necrotizing fasciitis we can write. Now coming on to MCQs. Serotyping of Streptococcus pyogenes is based on which of the following protein? It's the M protein. Streptococcus pyogene can be differentiated from Streptococcus agalacti by testing susceptibility to bacteriacin, and CAM test is useful for identification of Streptococcus agalacti. Okay, this completes our chapter. In the next video we'll be covering gas gangrene and associated infection. Okay, like, share, subscribe. Thanks for watching.